I'm going to introduce our keynote speaker now, Dr. Henry Brem. He joins us from Johns Hopkins Hospital in Maryland. He graduated from Harvard Medical School and trained in neurosurgery at Columbia University. He did a fellowship in neurosurgery and ophthalmology at Johns Hopkins and then joined their faculty in 1984. He helped build the Johns Hopkins Brain Tumor Center. He directs the Hunterian Research Laboratory. In 2000, he was appointed the Harvey Cushing Professor, Neurosurgeon-in-Chief, and Chairman of the Department of Neurosurgery at Johns Hopkins Medical School. Welcome, Dr. Brem. It was a pleasure. I met him this morning. Pleasure meeting you, and thank you very much for joining us.
Thank you very much. Firstly, in terms of credentials, I'm born and bred in New Jersey, North Jersey as well, and so I feel very much at home. I also feel very humbled speaking before you because of all the groups of people that I speak to. There's none more difficult than to speak to a group of patients who are not new patients, but have been through this, and their families, and many of the people I met this morning who've lost people to this devastating disease. So I appreciate that we're all here together and that we can have a conversation. This is a devastatingly difficult disease, and one that, you know, I and many of my colleagues have devoted their lives to try to improve. And certainly, you know, I'm very honored to be able to come back and share with you some of our thoughts about what's happening with patients with brain tumors, what progress we've made, and what challenges are ahead, and what some of the promising directions are, some work that we're involved with. I do think, again, it's humbling to be to see people like Al Masella, who's devoted his life to helping other people who've gone through what he and his family had, and so many other volunteers and people who've done so much to help push the field forward and taken from their own lives to do so. I really, you know, when I look at my career, and I've been at Hopkins now for 26 years, devoted with a singular objective of taking care of and improving brain tumor patients and their families. I have an enormous sense of gratitude to really each patient for the trust that they put in me, that they allow me to do what we do, which is, you know, complex neurosurgery. I feel that that's been a great privilege. It's a tremendous trust that patients put in us to do our best and to get them through this difficult time safely. I also think that when I look at the many, you know, thousands of patients now that I've had the privilege of operating on and taking care of, that it's an opportunity to better understand this disease. Certainly when you see something in its so many manifestations, you begin to understand it a little bit better. You certainly understand that it's not a simple disease and that there's not just one victim, but that the family and friends and everybody else is impacted by what happens with these cells that are proliferating within the brains. And I have always felt very strongly that for that privilege and for that opportunity, that I have an overwhelming sense of obligation to give back, and that it's not enough to just give patients the best possible medical care and to do what I was trained to do as a physician, but that we have a very, very strong obligation to change things, and that's why people come to us. It's not only for their own care, but it's really for the future, so that other people get better care. And I hope that you'll see this morning that we've tried to go in that direction. I think that, you know, we're proud of some of the changes that have occurred in the last decade or 20 years, but clearly we've just begun to scratch the surface of what needs to be done. So I'm very privileged to work in a great institution with a tremendous team of people who are devoted to helping people with brain tumors. This is in our department picture, we've in front of the dome at Johns Hopkins Hospital, we have one of the largest brain tumor groups in the United States. We have 6 full-time neurosurgeons who are all strong academic areas that they're developing in addition to their surgery, but all outstanding neurosurgeons. When you look at what makes a brain tumor center, it's complex. It's not just, boy, I found a good doctor or found a good surgeon or someone who either cares or has great skills. It really, if you look below the surface, and many of you know this as you've really delved into this area. So I've tried to depict a little bit of what is it that makes, a great brain tumor center, or a brain tumor center of what you need as a patient. And one thing is that it's a team of different specialties. It's neurosurgery, it's oncology, pediatrics, neurology, pathology, radiology, radiation oncology, nuclear medicine, ENT, ophthalmology, endocrinology, and there are many more, nursing, social work, all of them have to be integrated, talk to each other, and be the best in their fields in order to do the right things for our patients that we're simply operating on. Then when we look at our program, there's a tremendous amount of research that goes on. And that research, there's teams of people that are carrying out the research. There's vaccine research, drug development research, drug delivery research, angiogenesis inhibition, stem cell, biological therapies, brain tumor genomics. We've mapped out the genes of, Greg Riggins and his team working with Bert Vogelstein have published papers in Science this year showing the full genes of patients with brain tumors, and we've been able to pick out new molecular targets based on that. So very important science goes on that interplays with this. And then in the patient care, there's the clinical team with nurses, social workers, our colleagues in neurology and oncology and radiation oncology and so on. We have an outcome center, and you'll see some of the questions we've been able to pose to them for the thousands of people we've taken care of. What do we learn from the way we've taken care of them to how to improve it for other patients? And then in the specialized tumors, the pituitary center, skull-based tumors, pediatric brain tumors, and all those groups have their own sets of clinical colleagues, peripheral nerves and so on. And all of that, to paraphrase, it takes a village. Nobody does this by themselves. And when you get care, you should be sort of getting the benefits of a huge group of people who are there behind the scenes and should be available to you as well. All of this interplays, this research and clinical care, into clinical trials, into taking things from this to say, how do we make it better? And that's what a clinical trial is. And how do we prove that it is better? Because just saying it's better doesn't really do anything. It really needs to be demonstrated. And for that, we've, NABID and now recently been merged with the UCSF group. We have a consortium of hospitals that are centered at Hopkins that are doing clinical trials from the NIH and sponsored by the NIH. There has been efforts, and we've looked at many, many drugs and therapies utilizing that tool. We have our own clinical trials. Many other hospitals have things that come out of our laboratories. We try to very quickly get into patients through clinical trials. And then I would say, training is also a major, it's not a byproduct, it's a major focus, because I really believe, as you'll see as I go through some of the things today, that we've made some progress, but it's our trainees who are really going to change the disease. It's the next generation as well, and we feel it's a very important part of our mission to make sure that the young neurosurgeons, the young neurologists and oncologists have the best possible scientific training and the best possible clinical training, and that they think about brain tumors, that we focus them on your problems so that they can really bring all this terrific science to benefit patients. When we look at the research that is going on at Hopkins, it also starts getting divided into different groups. And we have, in our neurosurgery department, we have 14 separate laboratories focused on brain tumors. The Oncology Center has many, many laboratories, ranging from genomics to proteomics to, and all of us, work together, and all of us share a common mission. All of us meet regularly and make sure that any advance from any group, scientifically or clinically, feeds back into eventually leading to better vaccines, better therapies, better drug delivery, and so on. So what is the problem? And I think all of you know very well that the statistics, there are some 20,000 people a year who are diagnosed in the United States with gliomas. About half of them are glioblastomas, the most devastating. 7.4 cases of malignant tumors of the CNS are diagnosed per 100,000 people a year. So you see all this newspaper hype, you see these magazines, and you see that there's a cancer cure here and a cancer cure here, which is very hope-inspiring and devastating to patients who have this tumor, because they say, well, good, there's been a big advance, and then they say, where is it? Why don't I have it? Now, of interest, this is from 2000, this is in the 1990s, and it's about anti-angiogenesis, actually, and it was a breakthrough from Dr. Hopkins' laboratory, and as you've heard this week, the FDA approved an anti-angiogenesis therapy, so things take a long time. And patients always ask, and while it took so much time, a lot of people died. And, so the question is, why does it take so long? And that's something that, I hope I can explain a little bit today, although it needs to go faster. So when we look at the spectrum of research that takes place, that we're involved with, it really is not just laboratory work, and it's not just, the basic science work, but it's really going back to pre-hospital social factors, health systems, where do people get their care, how do they get their best care, clinical diagnostics, how do we improve the diagnosis, how do we follow people, and then once patients are diagnosed and in our treatment system, are the treatments effective? Are we looking at the outcomes, and what can we do to bring up the things from the laboratory and into the hospital care? And then finally, after we do the treatments, what about the quality of life? What have we done to people with our therapies? Is a small increment in survival worth it if the quality of life is very poor, or do we give good quality of life and even a small or a large increment of life that would be more valuable? So we need to look at that. What happens after we're done treating people? So all of these are very important areas. All of them take an investment of time, energy, and funds to answer questions to. So I'd like to start with a very rapid, just series of questions that we've tried to answer through looking at data. First, just some fundamental questions. Does it matter where you have surgery? Does it matter what hospital you choose? So we did a study in Maryland. The data is public data on all the hospital outcomes for brain tumors. Well, firstly, it's been very well established that high-volume hospitals get better results. It's true in heart surgery. It's true in pancreatic cancer. It's true in any, it's probably true where you take your car to be fixed. The places that do a lot of something are going to be able to take care of it in the most efficient, safest way than a place that's trying to figure it out on each. So we know it's been established that there's reduced perioperative morbidity and mortality, and again, that's been shown in many different examples. We looked at it for brain tumors, and we did a study, was published in Neurosurgery a few years ago, and looking at the cost and outcome of craniotomies performed at a variety of hospitals. What we found was interesting. When we looked in Maryland at the different hospitals that did craniotomies, it really was only two that did very large numbers, the Hopkins and the University of Maryland. Then some of the community hospitals did a handful, and then some did very few, just 5, 10 a year. When we looked at the mortality results, just simply 30-day mortality, and even for benign tumors, let's not talk about the resources that it takes to take care of a patient with a malignant tumor, we found that there was a 16-fold difference in 30-day mortality between the lowest volume places that do an occasional craniotomy and the high volume places like Hopkins or University of Maryland that do at least one craniotomy a week, is with the criterion we set. So here's no other variable, just volume, and a gigantic difference in mortality. The editorial when that paper was published was from Sloan Kettering, and it's worth thinking about. It says the government mandates seatbelts and airbags at considerable cost because they reduce the mortality and morbidity associated with car accidents. It's surprising that there's much debate regarding the value of care at high-volume centers when it costs relatively little to reduce the death rate from craniotomies for tumors by 50%. So, all right, so then the question is, well, how much should the surgeon take out? Does it make a difference? I mean, you've probably all heard that. Does it really matter whether you got 10%, 20% of biopsy, a surgical resection? So we looked at that, and these are all, now the next series of papers were all published within the last year, 2008, 2009, and it's from our outcomes group, and basically looking at about 1,100 patients in the last 10 years that we've operated in Hopkins. And so the first question that was asked, and these are some of our co-authors, extent of surgical resection is independently associated with survival with low-grade tumors, with the less malignant tumors. And you look here and you see that the first group here, the subtotal resections, that actually this is what a subtotal resection looks like. There's the tumor, and then you can still see there's still some enhancement around it after the operation. This is what we called a near total resection, where there's only a little bit of enhancement around the surface where the resection site. And this is a gross total resection, where here you see the preoperative tumor and the postoperative scan, there's no enhancement whatsoever. And what we showed is that for overall survival, these are low-grade tumors, the gross total resections had a much higher percentage living 10 years later than those with a subtotal resection. For progression-free survival, the gross total resection group did better. And for malignant degeneration-free survival, that group that degenerates into higher grade tumors, it's much less likely when the ones underwent gross total resection. So does that hold true for malignant gliomas? I mean, that's true for low grade, so we looked at it for malignant gliomas, and again, it's the same thing. We looked at 1,200 craniotomies, consecutive craniotomies, non-selected, that we did for malignant astrocytomas, and you can see that those with gross total resection, independent of everything else, live longer, their median survival is longer, and they have a longer life expectancy. So that's very important, and that's true at first operation, and it's true at second operation. At second operation as well, getting the whole thing out is better than not getting it out. Well, so what's the message to the surgeon, or for you as patients to the surgeon? Just get it out at all costs, right? I mean, it doesn't matter if you hurt the person, just get it out. So we asked that question. Does it matter? In other words, should we be more aggressive as surgeons? I mean, there are many times we can't get the whole tumor out because it's in eloquent areas, it's in speech areas, and so on. So he said, does that matter? So we looked at that question, and we said, well, if maximal surgical resection is the goal, then what's the effect on survival for patients with malignant gliomas of surgically induced neurological deficits? In other words, a patient before the operation could speak normally, afterwards they can't, or before the operation they could walk and now they can't, or use an arm and now they can't because the surgeon was so aggressive correctly trying to improve survival that they hurt the patient. So we found actually, which is not a surprise, but that in fact if you, for 300 consecutive patients now only with glioblastomas, that the patients who had a new neurologic deficit, be it motor deficit or speech deficit, died sooner than those who didn't have a deficit, independent of the degree of resection. So actually this challenge, the difficulty for the surgeon, it's not just getting it all out, but it's getting it all out safely. And that's obviously more difficult than just one or the other. So we both, to be safe, you can take out the minimum amount. To be improved survival by taking out the most, you have to risk a deficit. So again, it speaks to working with surgeons who are maximally experienced, who really understand where the borders are of our current science and being able to do this, and also have the best technology. Do they have intraoperative MRI? Do they have ultrasound? Do they have techniques and navigation, of course? Do they have the techniques at their disposal as they need them in order to prevent deficits and yet get the maximal resection? Very simple questions, but very important to understand. And enhancement, is that important in low grades? We just, published that. Yes, those low-grade tumors that enhance do worse and therefore should be treated. It's our hypothesis with radiation or chemotherapy, because there's a debate. Do you treat low-grade tumors if there's some residual after surgery? If they enhance, they do worse, and therefore, it's our current conviction that they should be treated more aggressively. Now the question is, well, are there inoperable tumors? Are there tumors that surgeons shouldn't touch? And one of the answers to that was done by Dr. Olivi and John Weingart in our group, where they are able to show that one of the untouchable areas in the brainstem, actually is accessible with some new technology, utilizing stereotactic devices and very precisely entering from above down into the brainstem. It's sort of counterintuitive because it's a longer path, but it's a safer one. And they, in fact, showed that contralateral transfrontal approach is safe even in the middle of the brainstem. So it opens up another frontier of being sure that we're getting the right diagnosis. Well, does it make a difference just because we can do it? Is a reason that those patients who have brainstem lesions shouldn't just go to radiosurgery and get Gamma knife and get treated? Does it really change? And I just give you one example of where it makes a difference. A 45-year-old man came to us with progressive neurological deficits. Everybody thought he had a glioblastoma, and he was recommended to have Gamma knife. He came to us to have the Gamma knife. And in fact, Dr. Olivi said, this is what it looks like. All the radiologists felt it was a glioblastoma, and this is what it looked like. They did a biopsy, and it was multiple sclerosis. So the worst thing that he could have had would have been radiation therapy, which would have devastated his multiple sclerosis. So tissue is very important, and we're finding that there are no areas of the brain that we can't access tissue. So we're learning, and we're getting better technically as well as medically. What about some of the quality of life issues? I know that Tug McGraw Foundation is very concerned about looking at these things. Are these being adequately addressed in our patients with brain tumors? So one of the ways, it's hard to tease that apart because you say, well, gee, anybody knowing that they had a glioblastoma is going to get depressed. Isn't that appropriate? Do you really want to treat an appropriate response as the counter-argument? So one way we looked at it is we said, well, what about people who come in depressed? And how do you judge that? They're already on antidepressants before the diagnosis is made of a brain tumor. Well, that would select a population within our patients of brain tumors. And so we looked at that group. And again, this was just published last year by the Outcomes group at Hopkins. And actually found that depression is a very serious marker for mortality from glioblastomas. So if somebody's depressed and you're not addressing it, or at least that's the presumption, that we can alter that by improving it, they don't live as long. It's not just that they're not happy. It's also about survival. So we need to focus on these quality of life issues. Depression can't just be accepted as well, what do you expect? It has to be aggressively treated as well. Other things we're looking at, these are just patient management issues. What about glucose control? Everybody's on steroids, and a lot of people get into diabetic problems. Is that a big deal, or is that just it passes? And just in the scheme of things, it's not that important. So actually what we found is that in 2,300 craniotomies that we looked at, if someone had high sugars during the postoperative period, that actually it was a problem. We saw lots of patients, 22 patients who had that, and that in fact their mortality was higher, and that it was an important variable. So we also said, what about in the outpatient setting? So we're working very hard on controlling glucose intraoperatively and giving insulin drips while we operate to make sure that as we load people with steroids, that we don't let the sugars go up, because it's actually predicts a bad outcome if the sugars get too high. That's something that nobody paid attention to 5 years ago or 10 years ago. It just wasn't a big deal if you asked about it. What about in the outpatient center? And there again, we just published this paper, Persistent Outpatient Hyperglycemia. These are all, 2009 publications. They're out there for all neurologists and, primary care doctors and neurosurgeons to see, and actually showed if someone has persistent hyperglycemia in the outpatient setting, it's a predictor of early mortality. So not treating diabetes is not a good thing, and so therefore we need to be aggressive at watching how much steroids we give people and what the major side effect of the steroids is. And then that's both for low-grade and for high-grade tumors. So again, this spectrum of research, what are some of the other areas? Well, you know that all of these, many of these advances, these are just from looking at our clinical work. What about all the laboratory work? And I would summarize, sort of categorize that we're looking at targeted therapy as a catchphrase that's used very commonly now. That what does that mean, targeting therapy? So I've divided it into 3 different types of targets. One is targeting it to get it into the brain. That's a huge barrier for many of our therapies. A lot of things work in other parts of the body, but we have not worked traditionally in the brain because the brain protects itself. So that's one type of targeting. The second type is, what are we targeting? Is it cancer cells? Is it blood vessel cells like Avastin? Is it immune cells like the vaccines? Is it stem cells? Is that the proper target? Is that why we fail in our therapies? And I'll come to that at the end of the talk, because we're neglecting the stem cell population of glioblastomas. And the other targeted is, who are we targeting? Who should get what therapy? As we get more sophisticated, as we get more expensive, frankly, as we get more toxicities from the therapies, are we really picking and choosing the patients who will benefit from the different therapies? And I'll come to that at the end as well. So in targeted therapies, when we think of how to deliver drugs, we developed with my colleagues at MIT, Bob Langer, a polymer that could release very high molecular weights, very high concentrations of drugs directly into the brain. So this is what a gliadel wafer looks like, and we did the laboratory work in our laboratories working with Bob Langer, and then we did phase 1, phase 2, phase 3 trials across the country in Europe. Al asked me not to show gross pictures, so I'll just show you a wafer in a diagram. And the diagram just schematically shows the resection cavity, tumor's been taken out, and the concept is very simple. I mean, you have trouble getting drugs into the brain, you're in there operating and taking out the tumor. 90% of the tumors recur within 1 centimeter to 2 centimeters of the original site. Load up drug right where it needs to go. So if you just squirt it in, it goes away right away. It's gone in 3 minutes. But if you put in polymers that can release over several weeks, you can get orders of 1,000, 10,000, 100,000 times higher concentrations than you could possibly get by giving the same drug orally or intravenously. So to skip over 15 years of research and clinical trials, that led to the FDA approval, first for recurrences in 1996, and then for initial therapy in 2003. And that was based on 3 phase 3 randomized prospective placebo-controlled studies that we initiated and ran the first ones. It was the first time in 23 years that the FDA had approved any therapy for malignant brain tumors, since it approved BCNU 23 years earlier. So it was also considered a breakthrough in understanding what the FDA needed for data in order to approve a drug. We ask, again, simple questions. What about with Timidar? And I'll come back to Timidar, but let me just sort of jump the gun a little bit. Timidar is used widely. Can they be used together? And do they do better together than they do alone? And actually, this is published in December of 2008, looking at, in our experience with gliadel plus temozolomide, Timidar, after primary resection of glioblastomas. And this is probably the most important slide that I have, if I had one take-home message in terms of where the field is going. This takes into account the, firstly, if you look here, there's a survival curve of the standard way of treating brain tumors, malignant brain tumors in the past has been surgery followed by radiation, no gliadel, no Timidar. and the median survival was 9 months. And when we do that, we know that that's what happens. Average person dies in 9 months. That number hadn't changed in 30 years. When I was a resident, that was the number. The first 10, 15, 20 years I was out, that was the number. That's why people told me not to spend my career looking at brain tumors, because nothing had changed that number. 9 months. It was an incurable disease, and that's why there was little research going on, and that's why nobody was devoting their energies to it, because it was just considered incurable, and nothing that was thrown at it changed that 9-month number. Then we came along and we added gliadel, and this is Hopkins data, just looking back at our own data. And we found that we could change that from 9 months to 13 months for adult glioblastomas. And that was not enough, but it was real, and it was reproduced in multiple multi-institutional blinded studies, that we always saw that increase in survival and more long-term survivors. So that was encouraging, and that's why the FDA gave approval. Then Timidar came along, and actually, if you just treated with surgery, radiation, and Timidar, you got 15 months median survival. That's great. You know, we had another therapy and a pill, and that got FDA approval based on a randomized prospective multi-institutional clinical trial. So we said, why not combine both these new FDA-approved drugs, gliadel and Timidar, and that's our standard of treatment at Hopkins, is we resect maximally, we use gliadel on every patient that wants it and is appropriate for it, and then we treat all of them with Timidar and other therapies, and we found actually that we're getting a median survival of 20 months. So we've seen in the last decade, and this is, you know, after some 1,200 consecutive patients, we've seen more than a doubling of the median survival by using combined therapies of 2 new therapies. So on the one hand, that's great, and on the other hand, it's terrible, because nobody wants a diagnosis that they live an average of 20 months. But the reason it's great and the reason it's encouraging is it means we can make a difference. We can change this disease. This is not fixed. We can bring in new therapies, and they will change the natural history. If we can double it again in the next few years, if we can double it again, we're going to start to deal with a chronic disease and not a life-threatening disease. So that's my hope. I'd love the miracle drug that just cures it, but in the meantime, if we keep doubling it, if we keep pushing the envelope, we will see real changes. The degree of resection makes a difference with these. This is more of that data, but still the combination is the best outcomes that we've seen ever. Question, what about all the side effects with gliadel? And basically in 288 consecutive cases, and this was just published in the Annals of Surgical Oncology in 2009, and basically there's no difference between those and the other patients we treat. There's a low incidence of infection, a low incidence of edema that's treated with steroids and so on. So it demonstrates the proof of principle that controlled release with polymers directly to the brain is safe and improves patient outcome. There are other controlled delivery drugs. This is Taxol we've worked on for many years. Works for breast cancer, works for other cancers. Does not work when given intravenously for brain tumors. Does work very nicely in the laboratory when given with polymers. And so we've gone through a number of different iterations of that, but a phase 1 trial finally came to fruition using Oncogel. And forgive me, it's the one brain tumor, but I just want to show what the gel looks like. It just squirted in at the end of the resection, and that's what Oncogel, we've tried that in patients. We're in a phase 1. It's a safety trial. And I hate to say it, but after 15 years of research, that trial's been pulled because of lack of funding. So the company that's doing Oncogel has just said, stop entering patients. We don't have money anymore to fund the study. So we're in a holding pattern. I hope that the economy will improve, and I hope that many, many, many companies that are just pulling drugs now out of trials will restart. It's not greed. They don't have money. So there's nobody to blame except our economy, but it's tragic. In Europe, they looked at 5-FU, another drug that's used for liver cancer. My father was treated with 5-FU with benefit for his liver cancer. Can't use it for brain tumors, doesn't get in. They've done studies showing with polymers they can get in the brain. They see some improvement in survival, and they're pursuing that as well. Let's talk about Timidar for a minute. The key study was published in the New England Journal in 2005. and this is the survival curve for using Timidor, and it's on this basis that every brain tumor patient in the world, both those that are in the study and low grades and children and everything else, get Timidor because there's been this statistically significant improvement in survival. It's interesting to look at the results of the Gliadel and Timidor, and bottom line is they're almost superimposable, that you see the same type of improvement in the randomized prospective study with Timidor as you do with Gliadel, which as I've mentioned, you go from with Gliadel 10.9 months in the placebo group to 13.1 with 33% long-term survivors versus 6%, whereas in the temozolomide group it's 12.1 months versus 14.6 months, 10% in the radiation alone, and 26% long-term survival, so 2-year survivors. So you're seeing the same kind of right shift in these curves. And again, that led to why aren't we just pulling them together? Why don't we use Gliadel in the operating room and they immediately start chemotherapy and then follow it immediately with Timidor, which also has that benefit. My daughter, who used to be called Sarah Brem, she's now Sunshine because of her marriage, but she looked at it with polymers and asked the question, what about taking the same drug that's so nicely given by pill, could it be more effectively given by polymers? And in fact, in the laboratory, you can see here's it when it's given to rats by mouth, but when you put it in polymer wafers, it actually is even more effective. So we need to keep our minds open, and maybe the surgeon should be giving Timidor right up front, but that's another area that might be looked at. And then you look at, well, this combination in the laboratory of Timidor and Gliadel, both these, which have benefit independently, when you put them together, we see much better results than either one alone. And that's what that laboratory finding is the basis of our doing it clinically. So we always go back and forth. So we're looking at lots of combinations, and this just diagrammatically shows how we currently treat patients. We place the Gliadel wafers into the resection cavity. We give the pill with Timidor, which sprinkles it in down here. And we're seeing the other groups have reported 18.6 months. Now remember, 9 months is the median survival. The gold standard. We're seeing doubling that, and again, in our experience, 20 months. So why do so many people fail BCNU or Timidor? Well, is there a way to overcome that resistance? So Jim Herman and Steve Balin at Hopkins in 2000 published a paper looking at the MGMT gene, and showed that, in fact, with BCNU, which is the drug in Gliadel, that the patients who had that methylated gene did much better, that couldn't break down, they couldn't destroy the enzyme, did much better than those that didn't. So that was encouraging as a correlation. And by the same token, when the temozolomide Timidor study was published, they also looked at the MGMT and found in the same way the patients who had the methylated gene did much better with Timidor. So how do you use that information? You still give the drug to patients who have the unmethylated gene, even though they're not going to do as well, because you can't withhold one of 3 therapies that we have. So is there a way to overcome that? And the quick answer is that 0,6-benzoguanine binds that enzyme, does the same thing as if the methylated gene was there. We've shown in the laboratory that we can potentiate the effect with BCNU or Gliadel with that 0,6-benzoguanine. It's a safe drug. We did phase 1 trials with Gliadel that was published through NABIT by John Weingart, who's one of our faculty members, a senior neurosurgeon in our department. And the Duke group working with us have shown that with Timidor, 0,6-benzoguanine is safe and can eliminate that enzyme. And the RTOG is initiating a study looking at recurrent glioblastomas with 0,6-benzoguanine and Gliadel, because maybe patients won't be able to be resistant to it if we do that. Let me switch gears and talk a little bit about Avastin. And I'm just going to digress for a minute. And I do this not to point attention to me, but to just explain to you how long things take. I was very, very privileged, and the most important thing probably in my career development was I had the chance as a medical student to work with one of the giants in modern medicine, Judah Folkman. And as a medical student, we described in 1975, the first inhibitor of angiogenesis, and that was considered a breakthrough. We published it in Journal of Experimental Medicine and in Science with Bob Langer, that we could physically, a drug could inhibit angiogenesis, and that was the proof of concept. So from 1975, and I wrote a paper and actually won the Saul Corey Award for the American Academy of Neurology, that anti-angiogenesis could be useful for brain tumors based on that work. That was in 1975. In 2009, Avastin was approved, and we actually, working with Nobel laureate at Hopkins, Dan Nathans, we helped isolate VEGF and antibodies to VEGF, which is an angiogenesis stimulator, are what Avastin is. When it was approved for colon cancer in 2004, it was the first combination therapy. Mark McClellan, who was the FDA commissioner at that time, said that anti-angiogenesis therapy can now be considered the fourth modality for cancer treatment in addition to surgery, radiation, and chemotherapy. There have been studies showing that it's beneficial, at least symptomatically, in patients with recurrent glioblastomas. This week, in a really landmark decision, the FDA approved Avastin. I point that out because those of you who are supporting research, need to understand that anti-angiogenesis was discovered in 1975. Enormous amount of work went into it. This was huge laboratories. In the end, there were hundreds and hundreds of laboratories working on it. It takes time. So does that mean you shouldn't invest in research because it takes so long? Or does that mean that it's really important to invest in research even if you don't see the payoff till the next generation or till the next group of people? My conclusion clearly is that this is the right thing to do. I'm thrilled that I played a role in Avastin in 1975, and I lived to see that this is helping brain tumor patients in 2009. I hope that what we're working on genomics and basic science and stem cells now will sooner than that, but whenever, will help people with brain tumors in the future. In 13 years, the FDA, as you mentioned, has approved 3 drugs for treating brain tumors, gliadel, Timidor, and Avastin. It's good, and it's not good enough. Let me very rapidly go through some new treatment approaches. One of the things we're doing on drug deliveries, we're working with the same colleagues at MIT and computer scientists at looking at microchips. Instead of just putting in little wafers in the brain, we can put in biodegradable, and this is another paper in Nature in that collaboration. The NIH is funding this, to put in little microchips that can release multiple drugs in multiple time periods, late, early, at any time. So that's in development, and we're looking at that as a therapy. Stem cells, you hear a tremendous amount about. That's a complex topic, but they both serve for repairing the brain. There's a population of stem cells that can fix the brain. They're also good for delivery, and they're also a therapeutic target, which is what I'll mention here. So it may turn out that we've been off base all these years in how we approach cancers, is that all our energies are in the lower, if there's a population of primitive cells, cancer stem cells, you can kill all the cancer cells, the differentiated ones, the glioblastoma ones, but as long as those primitive stem cells are there, they'll just spit out more cancer cells. That's what happens. I mean, that explains, that might be right, it might be wrong, but it certainly explains what happens with glioblastoma. You take it out, you treat it with gliadel, you radiate it, the scans look good, and then what happens? You come back and all of a sudden it's back. You say, how'd that happen again? Well, maybe that population never went away of stem cells because we're not treating it right. We're not doing anything about it, and that's why it just keeps coming back and back and back. So we're studying that now, and we in many groups are really looking at that because maybe that's the right target. Maybe if you took care of the stem cells and the cancer cells, you could really wipe out this disease, and that's our hope. So one of the very promising things, and we published this in Nature, and this is in collaboration with colleagues in Italy who helped develop this work on brain tumor stem cells, is you can take a simple drug, bone morphogenic protein, it's used in spine surgery actually to stimulate bone growth, and actually in the laboratory, bone morphogenic protein makes those stem cells into normal cells. It differentiates them. So in a simple drug, BMP, you can transform that source of cancer cells back to a normal cell. If we added that, maybe we could, have another, 1-2 punch against these things. That's being developed. Individualized therapy, and I'm not going to go into this at all, just to say that there were, Greg Riggins heads a huge genomics program funded by the NIH and in the Ludwig Foundation, and they've mapped out the genes of glioblastoma patients. They found unique genes. They're exploiting that. They're finding new targets. Maybe we'll reach a point that we can individualize the therapy. This is my final, let me conclude on this. I think where we're going with glioblastomas is that in the future, when we diagnose a brain tumor, rather than just running to the operating room and taking it out right away, we may stop, biopsy it, send it to the laboratory, understand its genomics, understand its biology, design the right therapy, then go to the operating room, use all our techniques for maximal safe resection, put in the right local therapies that are designed for that tumor, not everything for everyone, but the ones that are right for that person's tumor, then have the patient wake up, then give the right systemic chemotherapy or biological therapies, and the right radiation therapy and gamma knife and whatever else is right. And then follow the patient, not just with current techniques, but with molecular markers. Look at, once we understand the biology better of these tumors, let's look at the genes that are important to that tumor and follow them with specialized PET scans, not the type that are available today. And then if there's tumor recurrence, rather than do a knee-jerk response of how it should be treated, going back and reanalyzing the tumor and then designing the right therapy. That approach would be a scientifically based, rational approach to further advancing brain tumor therapy. We're not ready for that yet. The science isn't there yet, but I think that's the direction that we're moving in. I'm going to skip over this. It's just about brain mapping. And also, I will just mention that we've done a very large-scale study about disparities in healthcare and for brain tumor care in the United States, and it's very disturbing. We looked at various huge databases, and that's been done in other diseases as well. And this is just being published now. It was presented at the National Neurosurgery meeting, but we looked at 76,000 people nationally undergoing brain tumor craniotomies in the 1988-2000, and actually found that we know, and it's well established, that big medical centers get better outcomes. The academic medical centers tend to have the most up-to-date resources. Well, older people are less likely to make their way into the academic medical centers. Minorities are less likely, and it's trending the wrong direction. It used to be closer to the same, and now it's less and less likely that minorities are accessing the large, high-volume hospitals with larger surgical caseloads. And not surprising, wealthier patients and those in higher income brackets and higher educations tend to be admitted to the academic institutions and the high-volume centers more than their lower wealth income counterparts. So that's just a fact of how American medical care is, and I think that it's something that we also need to be thinking about as a research topic for how we can improve access for everybody who has a brain tumor to get the best possible care. So my final conclusions, my final thoughts are is that by constantly striving for us as physicians and caregivers, by constantly striving to deliver the best possible care to all patients, and by asking and answering questions constantly, we really firmly feel that we can improve the outlook for our neurosurgical patients and for brain tumor patients. Thank you very much for letting me share all this with you. Are there questions or?
I have a question. I had a glio, and I was at radio in July, and I was told the standard approach, would include Panadol. It worked for about 6 months. It was very healthy. and stopped. Now I'm on Avastin. I'm just wondering, will the standard still be Temodor? If that doesn't work, you go to Avastin, or is there a possibility you'll go to Avastin before Temodor? Does that make sense? I'm not sure.
Yes. No, I think most of my colleagues in oncology, and the data is very suggestive, and I think the data becomes stronger, that Avastin should actually be used as a last resort, not as a first-line therapy. And the reason for that is after Avastin is given, it's hard to treat with anything else. So we think that the groups that have used Avastin up front as initial therapy are probably going to back away from doing that. So I would be very careful not to advocate for, so nobody wants Avastin to be more successful than me. Nobody's more invested in anti-angiogenesis therapy all my career, but I think Avastin improves quality of life, it improves the imaging, but it has some side effects, and it makes it difficult to treat with other therapies afterwards. So it's being used at the right time. In other words, it comes back, you've used Temodor, that's a reasonable time to use it. It's hard to operate on someone who's had Avastin as well for bleeding problems. So it needs to be used. It's extremely important, but we need to learn a lot about how to best use it. And there are also other anti-angiogenesis therapies that are broader, that are not just against VEGF, that are being developed and need to be utilized and might be used. I know that Jayshree Blakely in our institution is advocating using them before Avastin and then saving Avastin for afterwards. It's a very powerful treatment, and it's good. It's very good, but I would not push using it as the initial therapy.
Hi. You didn't mention meningiomas, and I wonder.
Meningiomas?
Yeah. I wonder, is there a specialized center for meningioma? And the other questions I have is that, can you comment on biological therapy and immunotherapy for things like meningiomas?
Well, meningiomas are extremely important, and I would say that most of my surgical practice is for patients with meningiomas, and I have many lectures about meningiomas, so I could talk all day about it. There are many issues that some are the same and some are different. Certainly the things like glucose control are the same, but the issues with it is a surgically curable disease or treatable disease, and so the issues are very different, and they're very individualized. I mean, there's a huge range between meningiomas that we can take care of surgically and those that require other therapies. As far as in other centers, I would have to say that the centers, the referring doctors don't distinguish between meningiomas and glioblastomas. So a center that sees a lot of patients with glioblastomas is going to, almost by definition, see a lot of patients with meningiomas and acoustic neuromas and pituitary tumors, because to the outside world, not to the people in this room, a brain tumor is a brain tumor. So it tends to be centered in the same places. So, for example, we operate on probably close to 1,000 patients a year with meningiomas at Hopkins. There is much less research going on meningiomas. It's very interesting. It's, it would be very high payoff because people have a normal life expectancy in general. But there's a lot to be done and there's a lot to learn. I am not aware of any vaccine trials for meningiomas. There have been some biological therapies that have not worked, like the day after birth, the RU486, the day after birth control pill. Big study was done and it was shown not to be effective. There are a lot of studies on radiation therapy and they're confusing. I think the mainstay of treatment for meningiomas is surgery. We also have very important clinical decisions about whether or not to operate on a meningioma in the first place. I have probably 1/3 of the patients with meningiomas that I follow I don't operate on, I watch, because if they're not moving along, if the tumor is pretty much stable, then it's safe because it's outside the brain, to keep an eye on it. So it's a whole nother topic, and it's a very important one, and I, of course, would be happy to help you or to help anybody with a meningioma, but it is a whole, in a way, it's almost like a different disease.
This will be the last question.
The question is the use still of carboplatin rather than Temodar, because it is said that the Temodar will actually cause the tumor to become more malignant. The Temodar has been shown to actually enhance the malignancy, or the side effects are not worth it.
Well, there are a couple things. I'm not aware of any data that Temodar enhances the malignancy and would be dangerous. There is also no data that Temodar would help a fibrillary astrocytoma in a baby. And that's where, I sort of mentioned that there was a lot of extractions from the data that was done that shows a small but definite increase in survival with Temodar in adult glioblastomas, that it's just used for every brain tumor, almost every brain tumor. Children, in particular babies, are really a whole different approach in terms of what's safe and what's not safe. Mm-hmm. For example, radiation therapy, which is standard therapy,
they don't want to do it till he's 10.
Exactly,
if we can make it till
exactly.
Yes.
They found, unfortunately, experience means making mistakes, but there were generations when little babies were treated with radiation, which is good for medulloblastomas. And what they found is that they were mentally impaired when they grew up. And so it was too big a price to pay for the improvement in survival. So now in babies, they do everything possible to avoid radiation and use it only, like I mentioned, Avastin as a last treatment, not as a first treatment.
Right, so I understood about the
Temodar
radiation.
doesn't have a basis of being used for a fibrillary astrocytoma. Mm-hmm. Carboplatin, it sounds like a reasonable drug, so I think it's a good course, and you have it in your back pocket if it needs to be done. I wouldn't hesitate to use it if it's necessary. I definitely wouldn't throw 100 treatments at a child because there are long-term consequences.
I see.
If it's working, you need to count your blessings and
Yes.
just and take advantage of that.
Great. Thank you very much. Very helpful.
Thank you. Thank you all very much.